Because we are going live. Yes. So, good morning, everybody. Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania, welcomes you on 49th non-stop weekly CMAAO meeting. And for me, it is 1791st COVID episode we are discussing. We have received some regrets from our chair that he will not be able to join today. Others will be joining, and also from South Africa, and others will be joining over a period of time. We have a special guest with us, Dr. Monica Vasudev. She is an allergy and immunology specialist, and I will be interacting with her for first 15 minutes. And we have also invited her as a permanent invitee. She is in US, and we have invited her permanently because in most of our discussions, the concept of allergy and immunology is coming. So welcome, Dr. Monica, to be here. Can you tell us something about you, about your specialty, so that everybody knows?
Thank you. My specialty is allergy and clinical immunology. I have a basic training in adult internal medicine and received further fellowship training in allergy in both children and adults. Part of the allergy training involves immunology because allergy represents one arm of an immunological response. I'm in full-time clinical practice. I take care of patients with asthma, allergic asthma, seasonal allergies, food allergies, and dealing with adverse reactions to medications, latex, and other agents as well. And so
I'll ask you some questions before we go back to our actual agenda. So my first question is, when you said that allergy is a part of regular immunity, so what is the difference between Th1 response and Th2 response when we call about allergic response? When it comes to allergic response, how does the body decides to open up a regular inflammatory response or an allergic response?
So when we have immune responses, we have multiple layers. You think of it as an army. You have the initial non-sophisticated, very strong reaction, and then you have the delayed, very sophisticated tactical responses. In the sophisticated responses, we have what's known as Cd4 and Cd8 cells. These are markers that are on top of lymphocytes that help. These markers help decide what these cells do, and these cells are determined by the cytokines or hormones that they produce. So CD4 produces Th2 or T helper cell type 2 cytokines, IL4, IL13, as well as the cytokine CD8 produces interferon gamma and other cytokines. CD8 are usually with response to viral infections and are non-allergic. The IL13, IL4 responses, IL5 responses of the Th2 or allergic responses are responsible for the involvement of IgE antibody, the production of IgE antibody, recognition of an allergen, and then the subsequent downstream events of when an allergen binds to IgE, lands on a receptor like a mast cell, and then releases chemicals such as histamine and tryptase that then cause allergic symptoms. So a Th1 response is more like fighting an infection, whereas a Th2 response, if it's exaggerated, would give you symptoms of allergies, your sneezing, your stuffy nose, your swelling, your hives, things like that.
So let's take 4 vaccines are available. One is RNA vaccine, where we have now Bangladesh also joining. So you have a RNA vaccine where the RNA goes inside the body, messenger RNA, takes over the ribosome, produces antibody, produces spike protein, and that against that spike protein, the antibodies forms. Now, if you take the Oxford AstraZeneca vaccine, it's a DNA which is carried by another virus. The DNA is released in the cell, goes into the nucleus, comes back, produces RNA, and then it becomes something like messenger RNA vaccine. So it's an extra process in that. So from antigenic point of view, will they be different? From antigenicity, from allergy point of view, Will they be different?
So it depends on what is the actual antigen that's being coded in the mRNA or in the DNA. With the mRNA, you're not having nucleus involvement, and you have the machinery that's already in the cytoplasm that is able to replicate the protein that's the spike protein in question. The DNA vaccines require a little bit more effort to get the DNA into the nucleus and then to utilize the mechanisms. However, if the specific coding of the spike protein remains the same, the efficacy is all going to be based on how they design the vaccine in terms of what is the nucleic acid pattern rather than the vehicle of how it's administered.
So we do expect the same type of, we do expect, Dr. Chaudhary and Dr. Russell is from Australia, and he is also the chair of UNESCO, who handles all Asian programs. Dr. Jamal Chaudhary is from Bangladesh. Dr. Monica is an allergy and immunology specialist. We have invited her as a special guest today to understand the concept of allergy reactions occurring. She will also be coming in my evening show today. And after this meeting, if we may also invite her as a permanent guest in Saturday meetings, because the subject of immunology needs to be understood more. So we need more specialists to join in. So my question now comes is, when I take a vaccine, irrespective of what vaccine it is, RNA or a DNA, we anticipate 4 reactions. One is called as, that we call them as immunogenicity, the allergogenicity. That means that there may be allergic reaction. The second and that allergic reaction may be IgE and non-IgE mediated. The second will be reactogenicity, where there is an exaggerated immune response, so which may be a type of a non-IgE mediated. And third will be a exaggerated inflammatory cum thrombogenic response. That means a Th1 response to the protein which is developing. So how do we differentiate them? First of all, how do we differentiate a IgE versus non-IgE mediated allergic response? I'm specifically in reference to COVID.
So an IgE-mediated reaction, and this is with respect to vaccinations, we don't expect or we don't know what the IgE response to viruses are. There have been studies looking at the effect of IgE responses to viral infections. We have an anti-IgE antibody called omalizumab. It's felt to be a seasonal control of people who have viral infection-triggered asthma. But I'm going to leave that aside right now. There is some work on it, but I'm not qualified. I don't know much about that. In terms of allergic reactions, when you have an allergic reaction, you have the allergen that sits on an IgE molecule. The IgE molecule is sitting with its Fc receptor on a cell surface molecule, such as the mast cell. The allergen sits on this Fc receptor, and then you have cross-linking of these two receptors. It sends a signal into these cells, whether they be basophils, whether they be mast cells, and it releases preformed mediators, your tryptase, your chymase, your histamine. And what happens is that you get an immediate, within 10 to 15 minutes, you'll get flushing, you'll get wheezing, you'll get hives, you'll get swelling, you'll get diarrhea, you'll get abdominal cramping, you can have fall in your blood pressure. Those are your symptoms of a systemic or anaphylaxis reaction. So that is how you know that this is a IgE-mediated reaction that has very similar immediate onset. What becomes confusing is that if these reactions become delayed, because then it could be mast cell non-IgE-mediated reactions. You can have complement mediated reactions as well. And so measuring a tryptase level can help with that. Looking at a complement consumption assay will help you with that as well. In those reactions where you have wheezing, flushing, hives, and that type of IgE presentation, when it's important to know the difference is the importance of recognizing and treating so that you know how to treat these patients. If you feel that this is an IgE-mediated reaction, you treat with epinephrine and a second generation antihistamine. We have cetirizine, loratadine, levocetirizine, fexofenadine. in North America that we typically use. We do not use the first generation 4 to 6 hour diphenhydramine. I think that's equivalent to like Avel, that's in India. So that is why it is important to understand the difference about the different type of immunological reactions, that when in doubt, if this is an IgE-mediated reaction, is that we need to give epinephrine to these patients, and these reactions will occur within 10 to 15 minutes afterwards. Whether or not this is an exaggerated non-IgE-mediated reaction, that's difficult to tell. Beyond the IgE-mediated, where you treat them with an H1 blocker or an H2 blocker, like the GI drugs, the anti-reflux H2 blockers, then that's when you start wondering, is there something else going on? And that's where you look at the trajectory of the symptoms. If they have an exaggerated IgG response, that's hard to know. That's dependent on the patient and whether or not how they've reacted to other immunizations, but in the context of the COVID vaccines, it's basically, is this IgE mediated or not? That's what we're looking at.
So how do we say, in a person comes to us with a history of allergy, 10% of the Indians are allergic. So in the first phase of healthcare workers, most of the centers denied them for getting a vaccine.
Yes.
Okay. But now the vaccine is opening up in a private sector. Those 10% needs to be given because they need to be protected. So broadly, how do I pre-medicate them? So do I follow them a protocol of Montelukast the night before and the Montelukast 1 hour before with H1, H2 blocker 1 hour before, which is a standard non-IgE mediated protocol. So do I pre-medicate these people or not? Or do I go for a scratch test?
Okay, so the Western guideline is we don't pre-medicate any of these patients. The biggest concern is pre-medicating with NSAIDs, ibuprofen, because some of the medications in that class can predispose them to having urticaria, angioedema in that setting. In terms of risk stratification, when it comes to those who have a history of allergy, and this is what I'm going to talk about in the talk tonight, the major component that is responsible for allergic reactions are known as excipients. These are the components that are added into the immunizations to help stabilize it, to make it more immunogenic. The Pfizer, Moderna, the Covishield vaccines have very few ingredients in these vaccines. And the one ingredient that seems to be common in the majority of the currently available, currently utilized COVID vaccines worldwide is the chemical known as polyethylene glycol, which can come in multiple molecular weights, as well as its cross-reactive compound known as polysorbate. And polysorbate and polyethylene glycol are ubiquitous in the healthcare industry. We see it in ultrasound gel, we see it in other immunizations, we see it in the foods we eat, we see it in the cosmetics that we use. But in the US, the way that we would screen for that is using a medication called Miralax, and that is a pre-colonoscopy prep medication or a constipation medication that is used as a laxative. Now, if they've had a severe reaction to that, that would be a reason not to administer the vaccine. Under other circumstances, even if they have a severe reaction to a prior medication, a prior venom sting, prior food allergen, that does not preclude you from receiving the immunization. I tend in those patients under those risk stratification prior to receiving the first vaccine, so we don't know, right, that these patients have reacted or not. I tell these patients to get their vaccines in the morning. I don't tell them to pre-medicate. I tell them to take medications based on their symptoms. If they carry an auto-injectable epinephrine device normally for their other conditions, I ask them to take that with them. I ask them to get their vaccine with another person, a family member that's from their household, so that they can take them to make sure. And so that we use common sense. The problem with pre-medicating with Montelukast H1, H2 blockers is that you might be masking that early onset reaction when those preformed mediators are released. If you pre-medicate those patients and say those medications wear off in 12 hours and they're still in the middle of that reaction, you don't know when those medications are going to wear off, and they will then manifest under a circumstance where it's more difficult to seek care. Better to not pre-medicate, better to get the vaccine, better to assess whether or not there's a reaction, and then treat accordingly in a facility that is able to train or to treat.
So in India, we don't have the system of carrying the epinephrine with you.
Yes.
That pens are not available; they are being imported.
Yes.
And so you are suggesting that because as on today, when there is a history of vaccine, a history of allergy, they are refusing to vaccinate.
So that's not a reason to refuse to vaccinate. It's all based on polyethylene glycol or polysorbate.
But that's not there in Oxford vaccine.
It is. Polysorbate is in the Oxford vaccine. I will show that to you tomorrow
So
or tonight.
polysorbate is in the Oxford.
Yes, it's polysorbate 80. So they're actually in all the vaccines. I don't know about Johnson & Johnson. Johnson & Johnson just got approved today on Friday in the US. I still need to look into that one. But I'm assuming that almost all these COVID vaccines have a polyethylene glycol or polysorbate excipient involved in them. But in terms of not carrying EpiPen, that's not a big deal. My patients are carrying EpiPen because they see me. But otherwise, these facilities that are giving the vaccines should have epinephrine available that they can draw up in the syringe and do a weight-based dosing that we normally do.
That
These
everybody.
EpiPens are,
That
yeah,
everybody.
but
I'm only talking about people carrying with themselves because after half an hour, if you get a delayed response, therefore I'm talking about.
then if it's a delayed response and you deal with the antihistamines, you're not going to have if you do have a severe reaction, seek evaluation. But the number of reactions that we're seeing, at least from the Moderna and Pfizer experience in the US, is about 11 cases per million doses. That reaction rate is very, very low for IgE-mediated history. So when we look at the influenza immunization vaccine adverse reaction for an IgE-mediated, it's 1 per million doses. It's 11 per million for these COVID vaccines, which is 10 times more, but the number is still very low. If these vaccines, if you're concerned about a patient receiving the vaccine, that vaccine should be administered in a facility that can treat allergic reactions.
So one more thing, and then that is that, say, I'll give you my own example. First of all is that Ig mediated may happen more in the second reaction because that will always happen. You need to be sensitized to a particular protein. So when you take the second dose, you may see more Ig mediated reactions. So therefore you need to be careful. The second thing which I want to say is that, for example, in my case, around 1.5 hours, my blood pressure shooted up. And I have now 10 cases where I have seen my blood pressure shooted up, not related to anxiety, because all the time I was live talking to people, relaxed, not bothered about the injection. So what immunological reaction can raise blood pressure after 2 hours? Because this we are seeing in 10 cases we have seen when the blood pressure has raised. So to the extent that we are telling, if you are a hypertensive patient, take pre-medication. That means 1 hour before, take your regular blood pressure medicine. But what can be, is it which immunological reaction will increase my blood pressure at 2 hours? Is it non-Ig mediated reaction which is causing blood pressure, or is it because Th1 response, which happens to my protein, when my protein is produced, and then Th1 response may not come less than 24 hours or 48 hours?
That's a great question. So Th2 responses lead to vasodilatory effect. That's why you get flushing, and that's why you get fall in blood pressure. We do not see a rebound elevation in blood pressure unless you're given epinephrine or you're given a dose of steroids. I am unsure of why you're seeing an elevated blood pressure. Sometimes it's just a sampling that people are checking their blood pressure more frequently under the circumstance because they are getting a vaccine, but I don't have an IgE-mediated mechanism explanation for you as to why your blood pressure went up.
So even the non-Ig mediated cannot cause high blood pressure?
That is, I'm not sure. Again, we don't know as much about the non-IgE reactions as we do about the IgE.
See, up till now we were thinking, see why we are talking about it, this may answer us the deaths in Norway. Because now I am asking everybody, because no vaccination center is checking blood pressure before and after.
Yeah.
So I'll give you 10 examples. One of them, say 3 in my 5 of us, 3 of us developed. My colleague, Dr. Prachi, BP shooted up. Ram Singh, my colleague, BP shooted up. My BP shooted up. One of them was symptomatic, two were asymptomatic. We just checked it up as an asymptomatic BP shooted up. The reason came is because one of the lady doctors, she said she developed hypertensive encephalopathy within 2 hours. She had to be admitted for 9. Then two of my more colleagues, medical doctors, their blood pressure shooted up. So blood pressure getting shooted is now we are seeing quite commonly. So we have to find out a mechanism. It is not sympathetic overlay because it is not associated with other signs of sympathetic overlay. So we were thinking either it is the protein taken up by the cell and it's something like a cytokine type of a response, some interleukin which has come and raised the blood pressure, or it is a non-Ig mediated response. We need to explain because see anything which is not in the evidence, anecdotal things we need to find out the answer. 10 cases in the last 1 week I have come across second dose of vaccine, blood pressure shooting up.
Are these people who are baseline hypertensive on antihypertensive medications, or these are non-baseline?
The classical example, my blood pressure is always 110 by 60 or 70. Never in my life, my blood pressure even became 120 by 80. It became 150, 94, 2 hours after vaccine, and then it subsided of its own.
I don't know.
Okay, we'll look into it, but then we are, because anecdotal examples makes and saves lives. So we have now made it I have to, all my patients have told them to get their BP checkup done because we still need to find out why Norway and people died, why people died in Germany, 33 in Norway and 10 in Germany. Something precipitated, we call them as reactogenicity. Reactogenicity is reaction to the virus. And then we have at least more than a dozen patients in India who developed MIA within 10 days of the vaccination. And that MIA, we are taking it for granted that they have a mini Th1 response in response to the protein. I call them as muscle COVID. That natural COVID versus immunization is a muscle COVID because we're injecting the same protein. And the protein going in the body can have exaggerated response. And that exaggerated response can cause accelerated immunoinflammation. Say, for example, the plaque, if a person has a plaque, which is at the verge of rupturing, and so he has an unstable plaque, which means there is a thin fibrous cap and a lot of foam cells and macrophage cells. If that person, if you give them the vaccine and the vaccine induced macrophage response can precipitate MI insusceptible individuals. Am I correct?
I mean, it is possible. I'm wondering if the blood pressure elevation is also due to the intense myalgia that sometimes is associated with it. I mean, the same mechanism that gives you myalgia. When I had my vaccine, 4 hours, first 4 hours, I felt nothing. I received the Moderna vaccine. And after 4 hours, it hit me like a brick wall. I was completely myalgic. I couldn't even move my arm. I couldn't even lift it above my head. And the rest of my body was myalgic for the next several hours. I think there's many immunological mechanisms that are being triggered when we receive these vaccines, these mRNA vaccines, or these mechanism of action vaccines that we're seeing now are being used on large scales that we've never seen before. I think that this is all information that needs to be documented. We need to have a way where we are able to keep track of all these symptoms on a national level, so that we can understand trends, we can understand at-risk populations, and maybe we can understand clustering of reactions if it's related to something else. And that's one of the things I'm even going to bring up tonight on the program, is that we need to have effective and reliable tracking systems. But in terms of the mechanism, these are all speculations. I'm not sure.
So when it comes to allergic reactions, if somebody has any question, Angelique, Dr. Sajjad, Dr. Jamal.
Yeah.
Yes.
Thank you very much. Good morning. Actually, it's nice to see Monica Basudev here. Actually, the name is familiar to me because we used to see your name when Dr. K.K. Agarwal used to send us the information actually all the time. So nice to meet you here. Thank you. Dr. Agarwal, actually, you are just advising pre-medications for vaccination who have got some sort of allergy or some diabetes and hypertension like that, comorbidities. So actually, I went this through the website of the CDC because my daughter, she is allergic to food and severe allergic to food. So that's why she's going to be vaccinated tomorrow. So I went through the CDC website. I couldn't find any sort of this medication advice. So Dr. Monica Basudev, does it practice? Is it practiced in the US? Somebody this or the allergic people involved?
I will come back to this. Monica, the literature I'm talking about up to date. Okay. So when I go to up to date, it mentions that if you want to prevent non-IgE mediated allergy, then pre-medication can be given. And that protocol they have given for that is Montelukast night before and 1 hour before, and H1, H2 blocker 1 hour before the vaccination.
This is pre-medication for what scenario?
Only non-IgE mediated. If you are suspecting non-IgE mediated allergy, okay, that's one. Second, there was an article in New England Journal of Medicine which covered the allergies, and it covered prominently in a photograph that both allergies can happen with coronavirus. You can have IgE mediated and non-IgE mediated. And IgE mediated will occur in the first 30 minutes. And most of our patients are seeing responses after 4 hours, 2 hours, 3 hours.
Yeah.
So we started imagining that this may be some sort of a non-IgE mediated reactions.
Yep.
So I have started recommending my patients that if you have a susceptible coronary plaque, means you have unstable angina. If you have a susceptible, means you have a known coronary artery disease, you have very high cholesterol, you have labile hypertension, then I says to prevent ACS, take pre-medicate with ACS, which is aspirin, colchicine, and statin 1 hour before, and take your extra dose of medication 1 hour before. And number two, those people who have some sort of reactogenic response, highly severely antigenic in terms of asthma, then we are asking them, we were advising them till today, pre-medicate them with Montelukast and H1, H2 blocker. Even myself, I took this combination because I am allergic asthma, allergic bronchitis every winter. So even I took a Montelukast and colchicine and cetirizine 1 hour before the vaccine. That's what is the issue of discussion.
So if you do that, and I'm talking about the mechanism of IgE-mediated reactions, you have the immediate preformed mediators, but then you have the production with the same stimulus that can then lead to subsequent symptoms that can appear 4 to 6, 8 hours later. Whenever we advise our patients to use an EpiPen for an allergic reaction, we don't say, okay, use your EpiPen and you're done. We say, go to the emergency room after you've used your EpiPen because of the biphasic reaction that can occur with IgE-mediated reactions. So if you pre-medicate, say you're taking Montelukast the night before the morning of, then theoretically, based on this mechanism, you should continue to use Montelukast for the next 2 to 3 days as well.
Yes.
Right? It shouldn't just be a pre-medication regimen. No, it should be a pre-medication post.
It is followed up for 3 days.
Yes. And then under that circumstance, then that would cover the reasoning. But the US guidelines are telling those patients not to pre-medicate unless they routinely take that medication. And there is a difference. Did I pre-medicate? I did not pre-medicate with any Tylenol or ibuprofen or acetaminophen or paracetamol. I did it after I had the vaccine, but I was considered low risk. If you are considering yourself high risk, like you, Dr. Chaudhry's daughter, then what I would say is make sure she gets her vaccine in the morning, make sure you're in a facility that has epinephrine available. But because of her history of food allergy, she's not at increased risk for this reaction. Versus the reactogenesis that you're describing, like that's a different risk factor altogether. And I need to look into that a little bit more. But yes, so, you know, there's what theory says, and then there's what practicality says. And to really minimize reactivity, the leukotriene receptor antagonist is only one of the pathways that is IgE mediated. Not every IgE mediated reaction is through a leukotriene receptor mechanism. That's where using the H1 and H2 blockers are very, very important.
So what I'm trying to say is that we have still not got an answer of 33 deaths in Norway, 10 deaths in Germany, multiple deaths of acute heart attack occurring in India. Okay. The answer is everybody, if there is a death, half an hour later, we will get a response not related to vaccine. So for government bodies, related to vaccine means IgE mediated reaction. In half an hour, if they do not get any reaction, it cannot be vaccine related. So some immunological response is occurring. Some immunological response is occurring, which is causing lots of symptoms after half an hour. So that symptoms we are trying to identify. We are trying to find out, because in a private sector, when a patient comes to us, we cannot have 13 out of 1 million. That means you can die, 13 out of 1 million can die. For a private sector, that 13 is a very big number. Die means anaphylaxis, sorry.
Yeah, this is not dying. None of these patients died.
Sorry. I said, no, but in India, we have deaths occurring. In India, we have seen the deaths occurring. So we cannot accept even a single death or a severe reaction occurring if we can prevent it. So once it is coming to private sector, we have to go back to be a little bit more aggressive and treat them. So Elvin also from Hong Kong joins. Elvin, you are not straightforward. You are on a horizontal. Correct your screen of the computer. Elvin, correct your screen. You are.
Yes, Mr. President, can I?
Yes, please. Dr. Sajjad is from Pakistan.
Yes, thank you very much, Mr. President. Very good presentation by Monica. I think it's a very important topic. I have two questions. Number one is myself is having allergic rhinitis. I'm an ENT surgeon. That's why I have by birth allergic rhinitis. So I had a virus. My wife was also suffered with coronavirus with 10 days fevers and coughing and everything. Thanks God we are alive. In this situation, when we get the vaccine, what precautionary measures should I get? As Dr. K.K. Agarwal said, that pre-medication should be done like the antihistamine or Montelukast. Should I take this before taking any medicine? Number one. Number two is that this vaccination center should be established in anywhere in the area, or it should be established within the premises of the hospital. What is your opinion? Because in Pakistan, we have a center with little arrangement for any anaphylactic shock or any allergic reaction. So what you suggest that what is the preference that the center should be with all the facilities, or it can be established in anywhere in the city? Thank you.
If I may, so I'd like to answer your second question first, and that is the setup of these vaccination clinics. In my opinion, these vaccination clinics should be made wherever a patient is able to go to get the vaccine. If you restrict how you place these vaccine clinics, you will decrease the ability to have your vaccines reach the population, and we will not vaccine fast enough. Why are we doing all these vaccines, and why are we doing it at this pace? Is even if you have asymptomatic spread or you have infections that are not causing death, you really want to prevent the spread of the infection, you want to create herd immunity, and you want to prevent further mutations. If you say that at the risk of, or for the benefit of preventing severe allergic reactions, that these need to be restricted to tertiary healthcare, large hospital setups, you will now lose a percentage of the population that will have access. You should have both. You should have hospital setup, you should have outreach setups. But the patient that chooses to go to each of these, if they have a choice, they should go to definitely a hospital setup if there's concern for an allergic reaction. But the outreach clinics should have the basics available to them in a facility that's giving injections. If they have the ability to have H1 blockers,
Yes.
H2 blockers, epinephrine available, blood pressure cuff, a glucometer to make sure that they're not hypoglycemic, all the other like things that we would consider when somebody has a syncopal event. Those are the things that I would definitely have available. In terms of the pre-medication from an allergic rhinitis perspective, we have such a high prevalence of allergic rhinitis and atopy that it's not even diagnosed, that we have many, many patients that who have underlying allergic rhinitis who are getting the vaccinations who have not had any issues. For your peace of mind, Dr. KK Agarwal has provided a regimen of pre-medicating with Montelukast the night before, the morning of, an H1 blocker, an H2 blocker the night before, the morning of, and to continue for 3 days. I see no harm. I do see harm in pre-medicating with NSAIDs because the use of NSAID has been known to be associated with increased risk for angioedema and urticaria in predisposed individuals in association with a viral insult. So if you have somebody who has a viral sinusitis or has a virus and takes ibuprofen or takes one of these NSAIDs, they might end up with lip angioedema, even though they've tolerated these medications before. That's why we say not to give NSAIDs. I think paracetamol is okay. It doesn't fall into the same COX-2 inhibition as the other NSAIDs do, but I would say that you do what you feel is comfortable. Some of my colleagues who are considering themselves at risk, who are physicians, said, I'm not going to pre-medicate for the first one, but I'm going to pre-medicate for the second one because I'm more at risk for having a reaction with the second vaccine, or I'll be more symptomatic. I think it's finding your comfort level that I would do it. But in terms of making it a blanket recommendation for everybody, my facility, just because I have the ability to treat reactions and recognize reactions, I prefer my patients to be unmedicated so that I can treat them, but that's not practical in the general population.
Thank you very much.
I want to ask one more question before I hand over to Alvin and Mari and Angelique to intervene. We have two types of situations. One is a patient who is vaccinated now gets COVID. Okay, that's one situation. The second situation is he is got a COVID and now gets an infection. Now imagine two situations. One situation is where you are producing neutralizing antibodies. In second situation, you are producing non-neutralizing binding antibodies. And we are getting a phenomena so-called as MISA, multisystem inflammatory disease of adults. So I'll give you anecdotal examples what we are seeing. A patient comes with COVID-like symptoms. CRP is, C-reactive protein is 40-50. NLR ratio is impaired. High neutrophilic, low lymphocytic. Total lymphocytic count is normal. Classical picture is a COVID. And we do an antibody test that's positive. CT scan is negative. And we immediately do for the COVID antibodies that's positive. So these are the cases we are labeling them as subjective, like anecdotal examples of MISA. And we are finding them, most of them have low thrombocytic count. Mm-hmm. Some of have them involvement of larynx, which is not there in the primary case. And some of them have involvement of the heart. So my question comes is that, do you think that non-neutralizing antibodies are becoming important in COVID management? And how do we identify whether the neutralizing antibodies are neutralizing or non-neutralizing?
We don't have access to that type of testing to understand the type of antibodies that people have produced. We know that if you get native infection, that you have the potential to produce a very heterogeneous immune response to different parts of the viral particle, and every person is going to build a certain amount of immunity compared to immunizations, where it's a pretty homogeneous immunity and it's consistently high. When patients have a altered, irregular immune system, there's a condition that we learn in our clinical immunology training, and it's called HLH, or hemophagocytic lymphohistiocytosis. And that's a condition that causes massive, massive immune response. And the patient doesn't know how to bring that immune response back to normal. And the constant revving up of the immune response in these patients end up destroying the human their host cells. In the case of MIS, I feel like I don't know enough about this. I feel like we've not understood everything that's going on as to why some people make these antibodies, yet these antibodies end up being more deleterious than being helpful in these patients. And whenever we have immune dysregulation, I think it's hard to understand and how to measure whether or not they're neutralizing or non-neutralizing antibodies. How many times do we clinically receive immunizations, routine immunizations, and then look to see if we even ever made antibodies? This is the COVID pandemic has been the first time that we have consistently been testing for antibodies. So I'm not sure. I think when you have patients and then we work backwards and you have the ability to check these antibodies, that we're testing these antibodies, but we are not testing these antibodies in every single person that's getting infected or had their immunizations to understand what happened. And then there's people who get the infection and then get the immunization, and then we're worried about an amnestic response as well. So there's multiple immune pathways that I think are determined by what is the immune system of the individual, what is the type of vaccine, what was the type of infections that you had in the community prior to the administration of the immunizations. I don't have those answers. Just like in India, look at the difference between India and the United States in terms of the rate of infections and the rate of mortality. I mean, we've had in the Western, in these countries, we're having such a high rate of mortality versus you didn't have as much of a mortality as we have noticed here. What is it in the immune system that is making you have more asymptomatic infections than us?
So do you feel that this HLH can be linked to COVID? One of my very dear colleague, a gastroenterologist, and he had a lymphoma in the brain. He was totally recovering, and suddenly he developed HLH and died. Can this be related to a asymptomatic COVID he developed? Or
I'm not sure, because HLH has like, you know, a phenotype. We see that they have persistent fevers, they've had enlarged liver, their spleen,
he had all the symptoms of HLH.
Yeah, I'm not sure. I think there's actually multiple pathways. We don't know enough about this virus and why it's running havoc. I think it turns on switches in different parts of the immune system in different people. We saw in that one publication in the New England Journal where this one person who was immunosuppressed, who carried the active infection for weeks and months, who they found constant mutations developing in that one individual. Right. So as you have mutations that are happening in individuals, they're going to be eliciting, triggering different immune responses. And I think we're all primed to have different parts of our immune systems. We have some people who are Velcro. They pick up every viral infection that's in front of them. And then we have other people that just walk right through an entire winter season without having any issues. I lived in India for 6 years. Before I lived in India, I got 2 to 3 colds every winter. I went to India, and since I've come back from India, which has been 20 years now for me, my rate of viral infections has completely changed. It's become much better. What is it that it's an issue of exposure? It's an issue of how your immune responds and what stage of life. There's an association of the immune system and the hormonal system for women, especially in terms of how they respond to infections and how their immune systems respond. But I don't know, like HLH is such a rare condition. It is such a rare condition. I've probably seen only 2 cases my entire career. And that too, it was in training when I was in a tertiary healthcare setting. that I don't know. I don't think it's been looked at, or I don't even know that people even know to look for it if they had a patient who had significant lymphadenopathy, fevers following an infection or an immunization.
My last question is there a scope of a vaccine boosters because of the COVID coming in?
Yes.
Yes.
Because Moderna, they're all doing studies right now. They've actually been enrolling patients to use the vaccine boosters as a way to address the variants.
Okay, so let's have Russell, everybody to have Angelique, Russell, Elvin to intervene. Dr. Russell, Angelique, yes, Angelique.
Thank you so much, Kaika, and thank you, Monica. And thank you, Monica, for being honest to say, I don't know, because that is true. And thank you for not spinning it. Thank you so much for that. I've got 3 questions here. One, is it possible that you can have a natural immunity against a COVID or SARS? The second one is, if your patient on routine blood tests and stuff do have a it's not normal, do have an IgE that is slightly elevated, would you then, on the fact that they've got a slightly elevated IgE, would you then recommend the Montelukast before the time, or just keep it in mind and know that that patient might be able to get a response from the vaccines if they're going to be vaccinated? And the third one is, if you do point of care antibody tests and it's positive, would you then at this stage recommend that patient go for a vaccine, or wait until, do the antibody test every 3 months and wait till the antibodies become negative? Thank you.
Fantastic. Thank you so much for your comments, and I appreciate your questions. Okay, the first question is about natural immunity. Natural immunity would be dependent on which part of the world you are in. So we know this is SARS-CoV-1. We don't know SARS-CoV-2, sorry. We don't know if the prior SARS-CoV-1 pandemic that had occurred several years ago would have conferred some immunity. We, in Wisconsin, I worked with a large healthcare organization. It has 70% of the healthcare share in the state. And what they did is they used a study to look at the seroprevalence of COVID antibodies in the month of June. So this is before Wisconsin, the state of Wisconsin, had received its peak. And they found an extremely low level of seropositivity in the general population. And those who were positive had known symptoms of COVID or were tested positive. So I believe that because this is a novel virus, that the natural immunity is very low. Again, the difference between infection and vaccination is that even if you've had infection, it is possible to have a very variable immune response. You could have a very low, you could have a very strong immune response. It's variable to the native wild type infection. But when you get the immunization, it's a very strong homogeneous response. Okay. Question number 2, elevated IgE. So most of my patients as an allergist do have underlying elevated IgE. One, it could be determined by what your lab set is for what is considered an elevated IgE. But having underlying atopy and an IgE does not necessarily mean that you're going to have a predisposition towards having a reaction to the vaccine. That's like saying, if I have an elevated IgE, I'm going to have a reaction to peanut, whereas you don't have a reaction to peanut. So in terms of pre-medication, I really feel that that's a personal decision. In my patient population who are atopic, who have had issues related to reactions to other medications, I've told all of them not to pre-medicate for the purpose of the vaccine unless they were usually taking these pre-medications. I've had 2 or 3 patients who developed hives 4 days later, which I think is when the mRNA started producing the proteins, but it was just an exacerbation of their pre-existing chronic urticaria. For you, if you feel like this is what you would like to do, the leukotriene receptor agonist is very safe. You take it the day before, you take it the morning of, you continue it for the next several days. You can take the antihistamines, the H1, H2 blockers the night before, the day of, and for the next several days. But we do avoid the use of NSAIDs because it can predispose you to urticaria and angioedema. Okay, the third question. I am so sorry, I forgot it. Let's see. Can you repeat the third question?
It was, sorry, do you need to vaccinate or do you need to do your antibodies chronically and then decide to vaccinate?
Yes, sorry, thank you very much. I did answer part of that question. So just because you have antibodies does not necessarily mean that you made the antibodies against the spike protein, or that you have enough of a spike protein antibody response to be able to confer benefit from future infection. I feel that the benefit of producing antibodies is that even if you've been infected before, we do know that antibody levels wane. Better to get vaccinated and develop that strong, homogeneous spike protein antibody that we know that lasts at least 6 months or longer. So I do not believe that prior infection and seropositivity precludes you from receiving the immunization. And maybe we need the immunization in those who've been infected to be able to combat the variants.
Alvin?
Yes, Mr. President. Thank you, Mr. President, and thank you, Monica. And nice meeting you here and having your very good advice to us. I have a few questions, and one just follow up the last question of Angelique. In fact, the Lancet had just published an article yesterday saying that if some already infected individuals have the vaccination, their antibody will surge up to 140-fold of those infected individuals. And so they suggested that perhaps we should do the antibody titer before vaccinating, because after all, 27% of infected individuals are asymptomatic. And so if for these individuals already infected, they could perhaps spare the second dose, and that could help roll out to all majority of the population earlier. And so in fact, I forgot to mention myself. This is Dr. Alvin Chen from Hong Kong. And in fact, last week or so, Mr. President had also suggested that if for those who were infected, in fact, we could really spare the second dose or even the first dose, because sometimes there could be a hyper reaction then for the cytokine storm. There's a possibility of such cytokine storm, that is the hyper immune reaction giving rise to multi-system syndrome. That might be a possibility. So I just wonder, this could be feasible if there is an antibody level before vaccination, as Angelique asked. And would also, have you experienced any persons who had already been infected and got the vaccination, they developed exaggerated reactions or adverse effects after the vaccination? And second thing is, for those with cancer in remission or during therapy, what's your advice on giving the vaccination? And the third question is, say, for the killed virus from China, and also for the AstraZeneca Oxford one in South Africa, said to be low in efficiency. And even for the new Johnson & Johnson, the efficiency is only about 60-something%. For such low efficiency, would it, facilitate the antibody-dependent enhancement that theoretically that could happen? And also so in fact, I know that Johnson & Johnson was approved in USA as well for such emergency use. So would you prefer Moderna and Pfizer with a 94% efficiency rate rather than Johnson & Johnson with only 60% with a possible outcome of antibody in dependent enhancement or for the mutation facilitation because of the low efficiency rate? Thank you very much.
Yes, thank you very much for your questions. The Johnson & Johnson vaccine was just approved about 7 hours ago in the United States. It received unanimous approval under the condition, with the condition stating that we are having a shortage of the ability to have enough vaccinations for the population. This is a single dose. Where I feel that this is important is what are we looking at when we're looking at these percentage of efficacies? We're looking at these percentage of efficacies of preventing severe disease. Johnson & Johnson was found to have not as much of an efficacy for the older population, but would be very, very good for the younger population, one dose and they're gone. And they probably, the younger population, had more of the asymptomatic infections, speaking to saving that second dose related to the Lancet article that was released yesterday. So I think that when we look at these percentage numbers, we have to really understand what were they looking at. We weren't looking at asymptomatic transmission. We were not looking at pre-existing and post antibody levels. We were only looking at severe disease. So I think that all of these immunizations, it doesn't matter what is available, that it is important that maybe even it's good to have a variety of immunizations as the virus mutates so that we have a pool and not just one type of immunization so that the virus mutates to be able to evade that particular immunization. I think it will add to enhance the herd immunity. In terms of patients who have cancer that are in remission, right now in the screening protocols that I've heard from my patients who do have lymphoma, they have been told that they are not going to get the vaccine right now. They've been told not to get the vaccine. I don't know if those patients who have lymphomas, especially hematological malignancies, prior hematological malignancies, if they're going to be able to mount an immune response to the vaccines. We do have surrogates. We use pneumococcal, capsular pneumococcal vaccines. We could test IgG antibodies to the capsular pneumococcal antigens and see if they are able to even mount B-cell responses. But we know that immune responses to diphtheria, tetanus, pneumococcal can vary even from the nature of the vaccine itself, let alone your own immune system. So in my world, if this is not a live vaccine, this is not a live vaccine, everybody should be able to get it. Anybody who wants it, anybody who has access to it should be able to get it. There is no contraindication to these vaccines unless you are allergic to the component of the vaccine, which is the polyethylene glycol or the polysorbate chemical. In terms of measuring antibody levels, we do not routinely measure antibody levels. And I do agree that those who have had prior infection, and if they get the first dose, we can spare the second dose. But that discussion becomes moot if you end up having the Johnson & Johnson in the mix here, where we have a single dose injection. I think that people here are very scared to do anything different than what the emergency use authorization was based on. And that was the studies and based on that. So when Boris Johnson was saying, oh, we should just give one dose and then, make sure that the majority of the population, and Dr. Fauci from the NIAID was speaking to that over here. Dr. Fauci has been very characteristically saying, we follow the script. We were told to do 2 doses and that's what we're going to do. But this is a real world scenario. And if you look at the immunological mechanisms, it makes sense. A patient's been infected before, they have some immunity, you give them 1 dose of the vaccine, now save the other vaccines so that the majority of the people can get it. We are in a race right now to get as many people vaccinated as fast as possible to prevent the asymptomatic infection and to be able to promote that herd immunity. I mean, I think we are fatigued from being in this 4th wave right now. I think that our world cannot sustain what we've had to do right now to combat this. And really, these vaccines are the light at the end of the tunnel. So we really have to address all the different barriers for why people will show hesitancy. And we're just talking about these things. I'm not even talking about all the anti-vaxxer theories that are out there, but it's really important to get that middle road of people who say, let me wait and see what's happening. Let's reassure them to say this vaccine is safe. We can risk reduce whatever concerns you have. And it doesn't matter if it's not the 100% super, performer vaccine, that we really make sure that we get these people vaccinated. I think these are great questions. I mean, in a theoretical and a research world, that's fine. But in a practical world, I think we're also at the mercy of what our national legislations are. And I'm living in a country where we're following it by the book.
I just want to add, in India, we have neutralizing antibodies test now, which is qualitative. They are using a pseudovirus, and they have prepared artificial ACE2 receptor and an artificial RBM of the virus, and they are trying to find the neutralization. We also have print tests for neutralizing antibodies. Then we have S1, S2 antibodies, that is specifically spike antibodies. And then we have nuclear capsid antibodies that's available. So as far as India is concerned, and then we are in a private sector, once the test is available and approved by the government, so you can get those testings done. And now to rule out a multi-system inflammatory disease in a natural infection, if you have absent and antibodies, and if you have a presence of S1, S3 antibodies, that's what they're talking about, maybe enhanced immune response, which is responsible for pediatric systemic inflammatory disease. So these tests in India, we have started doing it because once it is available, I not come out with some evidence to see what's happening to that. So Dr. Chong is our chair from Singapore. Dr. Chong. We have invited today Dr. Monica from Wisconsin. She's an allergy and immunologist. And on behalf of the group, I have also requested her, if whenever she spares some time, because every time we are discussing, we are becoming a half-baked immunologist here. So let's have a full-baked immunologist guiding us in future. Dr. Chong.
Thank you, President, and thank you, Dr. Monica Vasudev, right? Hi, I'm Dr. Chong here from Singapore. And I'm sorry I joined you guys so late because I'm moving office today and it's very stressful. So much appreciated just tuning in the last 10 minutes and listening to all that has been said and very good insight into the situation. I've got nothing to add at this point in time, but please welcome Monica to come back to join us whenever, because we are all, as President has said, armchair immunologists, and we need the real ones here. Thank you very much.
Dr. Russell.
Yeah, good day, Monica. I'm Russell D'Souza from Melbourne.
Well, I'm also giving you one more faculty for your programs.
Yes, yes, I am from the UNESCO Chair in Bioethics, and all my questions were answered while you answered Dr. Alvin and Angelique's questions. But I wanted to ask you, for someone who's in remission with the autoimmune lupus or so, which of the the live vaccine and the killed one, which should be done, and will it be useful?
I think that there's no contraindication to any of the vaccines.
Is it?
Because you're in remission.
But they're still on, okay. And if they're not in remission?
Then I would avoid the vaccines. Anything that can hyperstimulate your immune system in an autoimmune condition that's not in control is not a good environment. So for example, we become hyperimmune if we have a cold, a viral infection. We're hyperimmune if we've received another immunization. The shingles vaccine is a very big example here that causes a lot of symptoms in our older population. So when we ask our patients to get the COVID vaccine, it's very clear that they're told not to receive any other injection and should have no cold-like symptoms, which they're going to get screened for anyway. on the day of the immunization. Taking that same example, if you have an uncontrolled autoimmune condition, that would not be the environment because your immune system will not be able to appropriately make the immune response. Your whole immune system has been skewed.
Right. So if someone is not in remission, then they should be not taking any of the vaccines. Is that right?
For right now, yes.
Yes.
You would not, it wouldn't be beneficial. I don't know if it'll be harmful. It might be harmful. It might be not effective at all. It depends what the condition is. It depends on what immunosuppressive medications you are on. I have patients who are rheumatoid arthritis. They're on prednisone, they're on methotrexate, and they stopped their prednisone for 5 days beforehand because they talked to their pharmacist and they said, I am going to make sure that I'm not on prednisone because it's going to prevent me from making antibodies. And I said, well, that's going to make your rheumatoid arthritis worse. So what's worse, your rheumatoid arthritis or being on prednisone? Even if you're taking 5 milligrams of prednisone a day, you stay on all your medications, you get your immunization, you get both sets and then test for antibodies. Get one of those, finger stick tests that you can see if you made an antibody response. And if you didn't, then we'll figure it out. But you should not compromise your immune status in anticipation of the vaccine. But if your immune status is not stable, then I would not recommend the vaccine until you achieve stability. I mean, a few months here or there for very special cases is very different than the entire population trying to get vaccinated.
So in India, we classify a immunocompromised person on two things, immunomodulation or immunosuppression. If he's on an immunomodulation dose, which is less than 40 milligram of steroid or say 15 to 20 milligram of methotrexate, we do not consider it as a immunosuppression. And we say, go ahead with the vaccine. But if he's on a immunosuppression dose, even if he's in remission, we just tell him that your immune response may be low.
Yeah.
Yes, Dr.
Thank
Alvin.
you. Thank you, Monica. Thank you very much for that.
Alvin, you wanted to say something? Mary?
Oh, yeah.
Yes.
Yeah, thank you. Mr. President, I just like to ask the question that you had already answered about the immunoregulation or modulation or suppression. So those severe autoimmune diseases with still high doses of steroid. So you would suggest not to give the vaccination, right? Both Dr. Monica and Mr. President, you said that.
In India, our criteria is if you are on an immunosuppression, meaning higher than immunomodulation, then you may not get full antibodies. There's no contraindication, but there is given a rider, you may have formation of less antibodies. So in our form, it is very clearly written. It is not a contraindication, but it may form less antibodies than the normal reaction. Mari from Japan.
Thank you very much for always, and thank you, Monica, for the information. Thank you very much, and see you next week. Thanks a lot, everyone.
So I'd like to ask the chair to close the meeting.
Just before, Dr. Agarwal, just before ending, I have a question to Dr. Monica, that in USA we have seen in pharmacy the vaccines are given, and yesterday night actually I have seen that Walmart also has given the permission to go for the vaccination. So whether they are all equipped to this emergency measures and
yes, they would not be. They would not be allowed to give the vaccines if they did not have epinephrine available. Yes. Yeah. Because the people who are giving the vaccinations have all been trained to recognize reactions, or they would have a nurse that they would have on site during these vaccinations. Yes.
Dr. Chong.
Thank you very much. Most appreciative for this session again, President, for organizing it, and Dr. Monica Vasudev for joining us and giving us such incredible insights into the current situation regarding the COVID vaccines. I'd like to thank everybody for participating in this session again. And we really, really look forward to next week's session, where we can again have a healthy exchange of such insightful information. So thank you very much again to all, and we look forward to next week's session. Thank you.
So we'll send you a link. Dr.
Thank
Monica
you.
is also giving a lecture today at 7 p.m. Indian time. So Saurabh will send you the link. The times which suits to somebody, you can listen to her. Otherwise, you can, whenever you have a leisure time driving, then you can listen to that particular lecture. Thank you very much. We'll be back next week, same time. Namaskar.
Thank you for the invitation.
Thank you very much.
Thank
Thank
you.
you. Bye-bye.
Bye.
Thank you.
Dr. Chong, have you gone?